All right, I think let's go ahead and start, if that's okay with Sim. Thank you for joining us and for your flexibility with the schedule change. I'm Rais Vohra, the Interim Health Officer for Fresno County Department of Public Health, and we are going to be updating you on a lot of developments. I think we missed a meeting last week, so a lot has happened, and we have a lot to share with everyone. So hopefully you can listen in and also follow along because I'm going to share my screen. If you're not able to see my screen, we will totally send out these slides right after my comments. So let me share screen and get started. Okay, here we go. Hopefully your tray tables are up and your seat is in an upright and locked position, and that you've buckled up because we are taking off. I jest, but this Delta variant is very aptly named because it is indeed taking off. In terms of agenda, we're going to talk about drug overdoses and substance use, which you've heard me talk about several times before, but this remains a very important component of public health in our county, and something that I have some dedication and passion towards. So I want to share some updates related to that. Then we'll do a deeper dive into COVID and just all of the things that we need to share related to COVID. And then we'll end with some comments on climate health, which for better or for worse is promising to deliver the kind of pandemic level disruptions that COVID has delivered to us. So I think it's never too early to start planning for some of the things that we can expect from the climate changes. You might have seen this make the news if you followed the headlines earlier this week. In fact, these are just news stories that I pulled yesterday. The CDC has released a preliminary estimate that 93,000 people died of drug overdoses in 2020 while the pandemic was taking place. So almost one out of, for every 6 people that died of COVID, 1 person died of overdoses, which may surprise you because COVID got so much attention and overdoses have kind of been simmering on more or less the back burner for a lot of different reasons for many different years. But this problem didn't go away. In fact, it got worse during the pandemic. Out of those 93,000 cases, the vast majority of them were opioid deaths, 68,000 out of those 93,000. Other major causes of overdose deaths included cocaine and methamphetamines. We tend to actually have a lot of methamphetamine fatalities whenever our coroner sends off testing. So that seems to be more of a local problem on the West Coast than even opioids. However, opioids and methamphetamines are both huge problems in our community. In addition to causing the deaths that they do, they end up causing so much harm in terms of hospitalizations, healthcare costs, complications, permanent damage to these people and their families. This is really just a rampant epidemic that is not going to go away with just benign neglect or just ignoring it. So I urge you to educate yourself. I know not all of us are toxicologists. That's not my expectation, but I do urge you to learn about how your patients might be suffering from substance use disorders, because I can guarantee you that they are rampant and that your practice is affected in ways that can be improved quite a bit if you and your staff and colleagues were a little bit more attuned to substance use disorders. So this is, I like to say all hands on deck. This is an all hands on deck moment that everyone can help. First, we can give naloxone to people because so many of those opioid deaths that I shared in the last slide could have been prevented if naloxone had been delivered in a timely fashion. We know that naloxone works. We see that it works extremely well in our emergency departments and in our hospitals. We know that it works in our pre-hospital settings because our paramedics and our ambulance partners tell us that. And more increasingly in recent years, we've seen that it works at the bedside whenever bystanders or relatives give it to patients, even in their own homes. So this is really kind of the EpiPen model where we actually hand people the life-saving antidote just because minutes are so important. And the sooner this person gets the naloxone, just like epinephrine for anaphylaxis, the better their prognosis. So, and the state actually is kicking in some real good resources for this by providing free naloxone. So instead of having to ask the patient to pay $150 a dose, the state is saying, we have free naloxone that you can hand to your at-risk patients through a grant program called the Naloxone Distribution Project. We actually have public health nursing students in our department right now, and their summer project is really to get this naloxone distribution project up and running for as many people as we can. So if you need just technical assistance, if you don't have time and your staff doesn't have the time or knowledge to apply for this grant, it's a super easy grant. I've done it twice now for CRMC. We're doing it for public health department. And I'd love to help you do it for your agency, your clinic, your organization, your church, your school, your favorite library or coffee shop. This really needs to be something that's as easily available as A, fentanyl is on the streets, and B, as EpiPens are for our patients that suffer from anaphylaxis. The next thing that you should all do is, if you are a DEA prescriber, you need to get X-waivered as soon as possible. You've heard me say this before. It's not going to get any easier. You watch an 8-minute video and then you spend 5 minutes. So in the course of less than 15 minutes, you get your X-waiver. The X-waiver will allow you to start a patient on medication-assisted treatment. You've heard me talk about that before as well, but I can definitely talk to you one-on-one if you need to know more about that and you're ready to take that step. But getting your X-waiver is really another way that we can put a big, big dent in this giant surge of opioid deaths that we're seeing year after year. This last year, it was 30% higher than in 2019. So this problem, again, it's not going away. It's getting worse. We need all hands on deck. We need you to get X-waivered, and we need naloxone in our patients' lives. I've included some links if you want to follow up on the news, because like every major news station covered this. It's something that really, our families and patients are expecting it whenever they have a patient or a relative that's struggling with drug addiction. We all just need to, step up and just kind of put this skill in our tool belt already, just because it's something that so many people are struggling with, and there's so few access points right now. But the government is trying to make things easier. The state is trying to make things easier. We just now need to step up and actually take advantage of these opportunities that are out there. Any questions about that before I move on to COVID? All right, okay, let's talk about COVID. Bottom line is we are headed for some turbulence, folks. Statewide COVID cases are taking off. Local Delta cases are increasing, and I'll show you a press release that we've prepared. We're probably going to release it later today. We can expect an upslope over the coming weeks, and I'll show you some graphs in a minute. Hospitalizations and deaths are also starting to trickle up, but I'm afraid that they are going to come back up in a significant way in the coming weeks. Obviously, I don't have a crystal ball, but this was how it felt whenever we had our last two surges. Was we saw our community case rates rise after a major holiday. And here it is 10 days, 15 days after July 4th. And we're seeing our case rates rise after that major holiday. And then that led to a precipitous incline in hospitalizations and then a very tragic increase in the number of deaths that we saw. The Delta variant is making things a little bit even more high stakes because it's causing breakthrough infections. So people that are fully vaccinated are now describing breakthrough infections, and some of them are landing in the hospitals with very sick cases of pneumonia. Non-vaccinated people's, I would be very worried if I was a non-vaccinated person right now and I understood the science, especially those that are doing high-risk activities like not using masks indoors, congregating with other people that are non-vaccinated, or even most tragic, they have occupations where they are forced to be in a public service sector and they haven't chosen to get vaccinated. They're just sitting ducks and they're going to catch the Delta variant. I can't say that any other way. Vaccinations, however, do remain protective against the vast majority of cases with Delta variants. And we know that with data that we're compiling locally. Our epidemiologist, Dr. Kumar, has studied this probably better than anyone in our county. And if she's on, she can probably answer specific questions that you have. But the bottom line is the vaccinations still remain protective. That's why you're hearing every federal agency trying to get people vaccinated as soon as possible. We just need to finish this layer of protection that we started. And unfortunately, it has stalled in recent weeks and months. We just need to finish building this bridge, as it were, and really get to the other side of this pandemic. And the best way that we can do that is still with vaccinations, because they are still protective, even against these variants that are coming out. People have asked us about booster shots, and one of the companies, Pfizer, has actually advocated for a booster shot, meaning a third dose of the Pfizer product. However, right now, the conventional wisdom and the FDA and the CDC are putting out this message. They're not ready to recommend booster shots in the general population. More information and more research is needed to find out exactly who is at higher risk of getting a breakthrough infection and who needs to have a booster shot. In my opinion, if you and your patient want to go outside of that conventional wisdom, then I think you have a very credible case to make. If the patient happens to be immunocompromised or has a solid organ transplant, in which case they are going to be taking immunocompromising medications, or they have some other disease process, perhaps an autoimmune disease, et cetera, that makes them immunocompromised, you can consider giving them a third dose or a booster shot. Please work with us if you are going in that direction, because we actually have contacts that can check antibody levels and actually help you make a better decision and hopefully be a little bit more defensible, because obviously we don't know exactly what a third dose is going to do to a large population of patients, because that hasn't really been studied. And so you would be going kind of off label if you did that. We want to support you, but we also want to be as scientific and rational as possible. So work with us if you do have patients that want, or if you want to consider giving somebody a booster shot. Like I said, this is all going to be changing anyway. So if you want to wait a few weeks, you may hear more information about who exactly will be qualified to get a booster shot. But nonetheless, between now and then, please work with us if you or your patients are asking about a third dose. Hospitals are experiencing capacity strains related to non-COVID cases. So this is another piece of the COVID picture that I think gets underestimated, is that our hospitals and really all of our clinics remain very busy. And every time I work in the emergency department, you know, it's a very busy place because people have a lot of non-COVID issues that they're coming in for. And so we really just don't have that capacity to stretch even more if we have another surge of COVID. So I think that's really going to create some challenges for us moving forward if we have a huge uptick in the number of cases and people all check in at the same time. And then we also have some liability with our healthcare workers, because there's a significant number of them who are not vaccinated. And that leads to a lot of risks to themselves, to their colleagues, to the patients that they take care of, to their own families, and to our communities. And so some counties, and I'll share one county's experience with this, have actually gone so far as to mandate vaccinations for healthcare workers. And that's something that is certainly worth discussing. And I hope to get some feedback about that. But you know, that's something else that requires us to really pay attention, is because if our healthcare system is strained and then we start losing people that go out on leave because they get COVID, then that's going to strain our healthcare system even more. That's exactly what we experienced before. So it's not like we're even making this up. That's exactly what happened in the winter, and we don't want to be in that position again. So we need to strategize and think more intelligently about how we can avoid that situation from happening again. Let me show some graphs, and then I'll pause to take questions or comments. So this is basically our overall graph. You can see it starts in March and then goes all the way to the next March and then on into July. So ever since the start of the pandemic, we had two major surges here. I don't think that should be news to anyone. And it's really too early to tell exactly what the slope of this surge is going to be. I get the feeling that it's going to have a flatter slope than the past two, because these two surges occurred at a time when people were not well vaccinated. But it's really anyone's guess, especially with these new mutants that are more contagious and more severe in their infectivity, and they have higher viral loads and things like that, whether that will actually make the line even steeper. I'm hoping that it'll be flatter, but it's really anyone's guess. The more concerning graph that I saw last night was this one, and that's about test positivity. And just look at this yellow arrow. Our test positivity actually surged with our winter surge back in January. Then it fell very nicely to kind of a low level in May, June. And now look what it's doing. It's coming back up. And so that is another indicator that our numbers are getting increased. And here's a statewide indicator that our numbers are getting increased. I just want you to see these two maps of California where, blue is low transmission and red is high transmission, and yellow and orange are kind of intermediate. And you can see everything is going from yellow and blue mostly to yellow and now orange and even red. And that just means that transmission rates are getting worse statewide. Fresno is still in the moderate transmission tier, not that we use the tier terminology anymore, but it's important to know that case rates are rising fast statewide. And I think this kind of shows that. I know it's a complicated map and a lot of numbers, but you just need to know that statewide, everyone is kind of feeling this same observation. Here is just a lot of numbers that our local team has put together about the Delta variant. And I'm not going to belabor all of the different little boxes here, other than to say that we have had household clusters, some of 2 cases, some of 3 cases, some of 6 cases. We've had 1 case in a skilled nursing facility that ended up being a Delta variant, and we expect breakthrough infections. So out of the 21 Delta cases, 4 of them were fully vaccinated. So that's 20% right there, had a breakthrough infection. So again, I keep fielding emails and calls from some of you, and I really appreciate that, about people that are fully vaccinated, but then they ended up getting COVID. And unfortunately, the first question people have about that is, what is their variant status? And unfortunately, we're finding out about the variant status 2 to 3 weeks later. And so it really doesn't help us in real time in taking care of that patient clinically. But really, a breakthrough infection, you can assume that it's a Delta variant, because that's what we're finding for many of these cases. Not that you don't treat them any differently. You still ask them to isolate. You still treat them clinically if they need oxygen, et cetera. So again, this is a population-based epidemiology question more than it is a practical bedside question. More numbers here, but you can see that, we were getting very comfortable in the weeks leading into July, that our total number of daily positives was, hovering in the 30s, 40s, never really as high as 90, but then it went up to 100 just a couple of days ago. Even more concerning is that overall weekly totals. So the week that ended in July 7th, we had less than 300 cases. The week that ended July 13th, we basically have 500 cases. So that's a big increase. Like I said, this thing is taking off like an airplane, and I think this is just going to continue before it abates. But we are seeing very early signals that Delta and COVID cases overall these next 2 slides, but I'm going to include them in the presentation that you get emailed to you. So this is about an outbreak at a wedding. Ended in a fatality. And some of them were breakthrough cases.
Dr. Vohra?
Oh yeah, go ahead.
Your connection seems to be breaking up. We didn't hear any portion on the wedding example that you just gave.
Sorry about that. Okay, I was just saying that with this wedding, it was a wedding in Houston, Texas, where actually Delta-related clusters were described, including 1 hospitalization and 1 death. And it was, a family where people flew in from India. So it's not surprising that they had the Delta variant described later. This is a outbreak that was described in a gym facility. So that's what my kids like to do, is that they like to go to the gymnastics classes. And I'm sure a lot of us who are parents are enrolling kids in summer camps and other activities. And as you know, kids under 12 are not getting the vaccines right now. So this was a real concern whenever I came across this. This was 47 total cases in an indoor gym, of which 9% were fully vaccinated. So again, the vast majority of people that are coming down with COVID are unvaccinated. However, there are some partially and fully vaccinated individuals that are being described with this Delta variant. So again, we expect breakthrough infections with the Delta variant. And I'll let you look at that MMWR on your own time. Now, the vaccine still works. Like I said, the vaccine recommendations are unchanged, and we're just going to need to continue to do more research to know whether these vaccines are going to stay as a good layer of protection, or if the companies are going to have to go back to the drawing board and create some other kind of vaccine that is more specifically designed. I'm sure they're already doing this, but release some kind of vaccine that's more specifically designed for some of these variants that are now dominating. As you can imagine, this becomes kind of an arms race, because as soon as we select for a variant that evades vaccination, we have to create a vaccine that kind of attacks that variant. And then basically this virus mutating all the time just is always going to create variants that will evade vaccinations at some level. So again, it's a race against time, but right now it seems like the vaccines are effective against the variants that have been described, including the Delta variant. There's also something called the Gamma variant, which used to be called the Brazil or the P1 variant. We're seeing several dozen of those cases as well. Again, the story is very similar to the Delta variant. The vaccines don't work as well, but they still do work well. And so the vaccines are still recommended to protect you against the Gamma variant, which is the P1 variant. More references just to show you that for symptomatic disease, the protection seems to be 90 to 96% with the Pfizer, and also similar reduction, but still protection in antibody protection with Moderna and Johnson & Johnson. So I'll let you review those if you're curious to pull those references on your own time. This is actually a slide that the state shared with us just to show that variants are still susceptible to vaccines. So what I actually wanted to do about the Delta variant in Fresno County is actually send in the Delta Force, but unfortunately my team said that was a bad idea. So instead, what we're actually going to do is release a boring press release. And basically this will say that the Delta variant is concerning, it's spreading rapidly, and what we need to do is encourage everyone that's over age 12 and eligible to get vaccinated. That's exactly what we need to do. For those who are unvaccinated, be very, very careful. Use your mask at all times, which is what the rules are right now. And if you have any symptoms at all, regardless of your vaccination status or not, get tested. We really don't want to lose the other layers of protection that we had, and which worked really well against many aspects of this pandemic, which is the testing, the social distancing, the masking. Really, none of those have gone away. They don't get as much airplay, I guess, as the vaccines. But remember, all of those other layers of protection work together and synergistically. And this is a time when we're seeing increased cases and not a lot of interest in vaccines. We really need to use all of the layers of protection that we have, including masking, social distancing, and aggressive testing in our most vulnerable populations. So does universal masking actually decrease risk of spread? Well, the issue is it would if people actually did universal masking, but from state surveys, it's clear that people that are unvaccinated are the same ones that are not planning to mask. And so it really becomes less of an issue. So a masking policy, people are like, well, why don't you have universal vaccination? Why don't you have universal masking policy as a mandate? Well, the masking policy to decrease indoor transmission must actually change the behavior of the patient or the unvaccinated persons. And so if you have a non-enforced mandate, that's really not going to change anyone's behavior. I think people have kind of self-selected into whether they want to mask or not. And unfortunately, the same people that don't want to mask are the same people that don't want to get their vaccines. That's just how life is right now. We're trying to chip away at that, but that's just why even a universal masking mandate is felt to it's not going to have the same effect that you would think that it would if people were actually going to do it. Just some information here for your own information. If you're getting questions about face masks versus N95s, which one will protect against droplets versus aerosols? Just remember the N95s do protect against droplets and aerosols, but face masks may not protect against aerosols. There is a small but significant risk of aerosol transmission with this disease. So I really think N95s are the way to go, especially for higher risk, non-ventilated settings. Just keep that in mind whenever you're fielding questions from your staff, especially unvaccinated staff, about how they can best protect themselves. and really using N95s. And then what they call engineering controls, such as ventilation, opening windows, things like that, keeping doors open for air circulation. Those are all things that you can be doing to help mitigate risk while you convince your employees to get their vaccines. So this is something that's going to require more of a discussion, but I just wanted to introduce this topic. And that is that there may be coming orders either from the state or local level about what to do to protect our healthcare workers and really also to protect our patients and our communities. So there's possible actions that are being considered. And again, I'm not ready to commit to any course of action today, but I do want to hear from our healthcare providers and really work together to support a rational way moving forward, knowing that we really need to get our vaccination rates up among healthcare workers, and at the same time try to protect our patients as well. So possible actions may include weekly testing of employees that don't have full vaccination status, an N95 requirement for all healthcare workers while they're on duty, a vaccination mandate for all healthcare workers, similar to what we do with influenza, with exceptions given for religious or medical exceptions, or any other ideas that you have. Again, I'm looking at this, as numerically as I can, because I really feel like it should be data driven. Right now, we're in that yellow tier, like I said, but our case rates are rising. So, I'm not saying that we're married to these numbers, but for example, if our daily case rate, which is around 2.5 right now, goes to 7 or even up to 5, then, do we need to start restricting some activities or making some changes to help protect our community more? Should we start canceling some large gatherings or doing other things? Those are the kinds of, different restrictions that are definitely being considered right now. Obviously, no one wants to go back to the blueprint structure and try to micromanage every single activity in every different sector. But this is something that we do need to pay attention to because the data is telling us that things are getting worse and we need to pay attention to that. Now, this is interesting. You might have heard that Trinity Health announced COVID vaccine requirement for all of their employees. And that's nationwide going to be 117,000 employees. I really have to give props to them. I think this is showing a real leadership and courage in this space. And St. Agnes is actually a Trinity hospital here in our county. And I just want to, publicly lend my support to St. Agnes for making this move. I know that it wasn't easy, and I know that it is somewhat controversial, but it makes total sense to me to say, vaccinating or asking all employees to be vaccinated is the best thing we can do to protect against employees falling sick and then having outbreaks within the hospitals. You can read more about this just online. Their CEO has some nice quotes there. And like I said, I totally support the move that Trinity Health made in this space. And we're hearing about more and more hospital systems doing the same thing. So I think that this is actually nudging people to follow suit. Now, San Francisco Department of Public Health at the county level also made kind of a similar gesture. They basically, in their new health order, have mandated that high-risk workers get their vaccine by September 15th, whether or not it's fully approved by the FDA. They have a section on their website that I've linked here in the bottom right, and basically their FAQ gives you a sense of who should get vaccinated and then who has to get vaccinated. And under the who has to get vaccinated section, it says anyone who works in a high-risk setting is required to be fully vaccinated by September 15th. And it does not prohibit other businesses or governments from doing the same thing or for verifying vaccination status. And then they define high-risk settings as acute care hospitals, skilled nursing facilities, residential, homeless shelters, and jails. So they're actually lumping in even more than clinical workers as high-risk settings, and they're asking all of those workers to get their vaccine by September 15th. What steps must be taken? Well, the worksite has to require vaccination, and for folks that are not vaccinated, make them wear a well-fitted mask. They didn't mention N95, but they used the word well-fitted, and make them do a test once a week. So if you choose not to be vaccinated, then we're gonna make you wear an N95 basically, and we're gonna stick something in your nose once a week. That is basically what the San Francisco Health Officer Order says right now. I'm asking my team to look at that very closely. And I look forward to engaging with anyone on this call about how we could bring a similar approach to Fresno County to help protect our healthcare workers as well. Again, I want to introduce this. I'm not committing to anything. I'm not announcing anything. I just want you to have a heads up that these are conversations that are happening. I'm sure they're happening in every county in California, actually, and in Sacramento. So we will all learn more together about where to move forward from this. But, you know, San Francisco and Trinity Health are, in my opinion, the tip of the spear here. And I think that as the numbers get worse in terms of the COVID cases rising statewide, this is going to be seen in retrospect as a really smart move on behalf of both of those agencies. What are we doing with vaccines here in Fresno County? Well, our numbers, like I said, continue to drop off, which is very sad. And I don't know if you guys have seen this dashboard specifically. This is something that Joe and his vaccination team get from the state. And they basically tell us, you know, here's your goal. It's this little orange line. And here's the folks that are in quartile 1, which is the most vulnerable quartile socioeconomically. And then here's our population broken out by ethnicity, meaning Latinx and Black residents, and where we are in terms of getting them vaccinated. So we have yet to reach our goals for all 3 of these very vulnerable populations. And then it kind of gives you a sense of the total population that's involved. But this gives us a nice dashboard of how we're doing with our overall progress. We have more work to do. Then they break it out by zip code, which is really cool to see also. So these are all of the zip codes. And as you can see, the top 12 zip codes or so each have 10,000 or more residents that are still yet to be vaccinated, which gives me quite a lot of concern because those are our most vulnerable populations. And that just speaks to a large number of people that are still, you know, maybe we shouldn't call them unvaccinated because I'm an optimist. I'll call them pre-vaccinated. We just need to reach out to them. We need to work in partnership with them and really explain the risks that they're undertaking the longer they wait to get their vaccine and really get them fully vaccinated as soon as possible. But these are some of the dashboards that we look at. The bottom line is we have a lot more work to do to get our folks vaccinated, and we're trying to break that up as scientifically as we can so that we can approach all of these different areas and target them strategically. At the federal level, you know, young people still need to get vaccinated. The people that are eligible to get vaccinated, the 12 to 17-year-olds, they haven't yet had their vaccine across the whole country. Here in Fresno County, we've only had 23,000 folks in that age group vaccinated. And so even though they make up 11% of the vaccine eligible population, they've only received 5% of the vaccines administered. The White House is engaging, you know, teenage celebrities like this singer Olivia Rodrigo to help get vaccine excitement going among this population. I think we could all be doing more to reach out to these adolescents. And I think as schools start to reopen, they really can partner with us to host vaccine drives to really help identify higher risk populations that need to get their vaccine. And then obviously the Safe Schools for All Committee is trying to encourage vaccinations through some of the policies that they've set out in terms of the testing, surveillance, and quarantine guidance that they've put out, which differentiates between vaccinated and non-vaccinated adolescents. So just to give you a taste of some of the work that needs to be done, you know, our most vulnerable populations, some of our rural counties, and some of our young folks, all, you know, we need to work harder to get them vaccinated. And again, the stakes are higher now that our cases are rising. So we all need to really have those conversations every single time. This should be part of your medical history now, is ask if the person's been vaccinated, ask their reasons for not being vaccinated, and see if you can just move them towards that, making that decision to get vaccinated by providing clear scientific reasoning for why it makes sense for them to get their vaccine. Lastly, this is the last slide about COVID, and this is a study that Dr. Kok Kumar, our senior epidemiologist, is putting together. This is actually asking people their beliefs and behaviors related to vaccines. This is totally optional, it's voluntary. This is something that we really want to get a good, robust sample size. So please help us get this belief and behavior study filled out. If Dr. Kok Kumar is on, maybe she can jump on and see how our medical partners can partner with us on getting this filled out. But the link is provided for you here. I'm sure Sim and the communications team can drop it in the chat. And I'm sure this is something else that people can just be filling out while they're waiting to see you in your lobby and waiting area. It looks like there is a raffle, so that there is a little bit of an incentive with a gift card that will be selected by June 2nd. So there is a little bit of an incentive thrown in there. The questionnaire takes about 10 minutes, and it really helps us because it helps us know exactly what reasons people have for not getting the vaccine, so we can actually have targeted messaging about that reasoning and really overcome the specific barriers that we're encountering in our community about why people are still choosing to not get their vaccine. All right, any questions about COVID? I'm going to shift gears and talk about climate. So it's pretty hot. It's still pretty hot, but it looks like we're ending this little heat wave. You know, this got a lot of press as well this week, which is just how the Western US and California specifically is really just in the front lines of climate change. And this vicious cycle of climate crisis is now being seen more and more through an equity lens. And I think people are picking up on the fact that, you know, some residents of our county are better off than others. So in the same way that COVID really preyed on vulnerable populations, I really think that this is the next pandemic that's going to prey on vulnerable populations, those who don't have access to shelter, those who don't have access to resources to keep themselves cool, and those who are occupationally at risk. So some of the same risk factors for COVID seem to be overlapping with risk factors for climate health related effects. But even that is painting with too broad of a brush, because this is a totally different issue, and it's really going to require us to not take a back seat in terms of you know, showing some leadership in this space and really trying to solve these problems before they get worse. So this Guardian article actually featured my colleague, Dr. Renee Ramirez, and actually talked to a lot of people in rural Fresno County that are working in the agricultural sector. These are pictures from Fresno that they ran, and this is a national UK-based newspaper. Here's a graph that that our epidemiology team shared with me. This is basically looking at heat illness surveillance. So this top graph is temperatures by week from 2015 to 2021, and the black line is 2021. And this temperature basically just bounces around. As you can see, in the middle of the year is when things get hotter, which should surprise no one. And here it's like, you know, even though this heat wave made a lot of news, it doesn't seem to be out of the ordinary for the temperatures that we experience in terms of highs here in Fresno County on average. What you're not seeing is the lows. So really the definition of a heat wave, there's a lot of ways to define it, but really whenever the lows don't fall below 80 degrees Fahrenheit, that's when the weather experts really get worried, because buildings don't cool, people don't cool, and really just a lot of the health effects of heat are seen whenever the lows remain higher than 80 degrees Fahrenheit night after night. That's one of the definitions of a heat wave, and that's what we just came out of if you've been following the temperatures. So that's something that you don't see on this top graph. But take a look at this bottom graph, because this is why I'm sharing this slide. So again, the black line is 2021, and this is a syndromic surveillance of heat-related illness. And so there's basically about 40 or 50 different terms that can trigger this syndromic surveillance. You know, things like obviously overheated, heat exhaustion, muscle cramps, syncope, nausea, vomiting, things like that. So it's not a very specific measure, but you can see that there is definitely a signal here that aligns with what we experienced in terms of our heat dome. And that is that we basically had a big spike in heat-related illness that was caught by our epidemiology team, even while we were in the middle of the heat wave. That has fortunately come down, so it didn't get any higher. And it wasn't actually as high as the 2016 heat wave, 2017 heat wave that actually had even higher spikes in terms of heat-related illnesses. But this is one way that we're doing heat-related surveillance. And I think this is going to become more important to pay attention to and to refine moving forward. So just to show you that, these are the kinds of early red flags that climate throws at you, is whenever people start coming into the emergency department or calling 911 for heat-related illnesses. Obviously, on the occupational side, you're going to have more people calling out sick and having more sick leave, et cetera. So there's a lot of different ways to measure heat-related effects, but we need to be more sensitive so that we can start measuring, preventing, and mitigating the effects of climate change moving forward. But I just wanted to share these two graphs with you because I just find this super interesting. And like I said, this is going to be something that is going to affect all of us for years and years to come. My joke is, don't think of this as the hottest summer ever. Think of this as the coolest summer we will ever have. So again, my optimism is sometimes too much to bear. Anyway, this is the world picture. Changes in surface temperatures are basically going up and up and up. And the whole point of the Paris Agreement, which you might have heard, is to limit the rise of temperatures to under 2 degrees Celsius. And here they've already gone up to 1 degree Celsius, and it's making people very worried that if we get up above 1.5 to 2 degrees Celsius by 2050, that we will basically be living in a different planet. And there's going to be massive disruptions that lead to very significant health effects affecting billions of people. The New England Journal has actually run many great articles about this already. And to my embarrassment and shame, I haven't been following this as closely as I could have, but I'm trying to catch up and just educate myself. And so I just wanted to share one of the best articles that I came across, which is about the major health risks associated with climate change. And again, I'll share the link out with you whenever I send you these slides. But really, this is a poisoning issue. We're poisoning our environment with carbon. The carbon dioxide and other climate pollutants are leading to rising temperatures and rising sea levels. And all of that is contributing to what is more generally known as climate change, which leads to, increased rain in some parts of the country and the world, and decreased rain in other parts of the country and the world, and a whole host of other, environmental effects that ultimately lead to what they're calling exposure pathways. So you have extreme weather events, which can cause heat stress. You have effects on air quality, water quality, and I'll share more about what that means in the next slide. And then even our food supply, obviously with the drought, that has huge implications for what our farm workers and agricultural businesses are able to do, which has economic implications for us, but just the general food insecurity issues that are going to come from climate change really is worth paying some attention to, because that will lead to a lot of disruptions as well. Vectors and things like mosquito-borne diseases, tick-borne diseases, and even animal zoonotic diseases like COVID itself will have disruptions in their pathways and may cause increased health effects. And then social factors, including mental health and other civil strife that will inevitably result because all of these different frameworks that people are used to living within start to break down. So, I don't want to make this a total gloom and doom lecture, but I think it is wise to look at this as realistically as we can, and to try to at least assess what are some of the health outcomes that we're going to be dealing with. And again, this article lays it out better than I can. So I urge you to go back to this article, and they have really cool interactive infographics where you can click on all these buttons and actually learn more about all of these different ways that these different exposure pathways will lead to real human illness. And we're starting to see those now also. This is not something that is going to happen sometime in the future. We're starting to see those now. It reminds me of a great quote from a science fiction writer, actually, who says, "The future is already here, it's just not evenly distributed." So we are seeing that. The future, this is actually affecting some people more than others already, but it's going to affect more and more of our populations moving forward. Harmful algal blooms, something that you probably have never thought about in your whole career. And even me as a toxicologist had very little information about this. But guess what? This is going to be a fact of life, is we're going to be hearing more and more from the State Water Board, from California Department of Public Health, from other hazard assessment entities about things that are growing in our water just because of climate change. Sometimes this is known as red tide or green tide. Sometimes it's known as an algae invasion. But these are basically blooms that happen as a result of temperature, as well as chemicals and nutrients that allow these cyanobacteria, which grow into large, sometimes visible blooms, and they can actually certainly affect animal life, and sometimes even go on to affect human life with hepatotoxicity, neurotoxicity, et cetera. So I really had no idea about how harmful algal blooms until a couple of years ago, when we started hearing about this at the Poison Center. People were calling us saying, my dog got really sick. My dog started to have seizures right after we got home from swimming in the lake. Dogs are actually quite sensitive to cyanobacteria. Thankfully, it doesn't affect people as much unless you're a dog lover, and then you're not so thankful. But basically, this is something that in the human world, we're not as, I think, attuned to. But lo and behold, we're seeing more and more algal blooms this year than we have in the past. And this is just another signal that the climate is changing and it's going to have health effects. So I just put in some slides about harmful algal blooms, just in case you're a nature lover and you've seen these algal blooms growing. This is kind of what they look like. Some of our beautiful ponds in some of our parks here in Fresno County are also are even starting to have some of these algae overgrowths, et cetera. Not every algal overgrowth leads to a harmful bloom. You really have to have the right combination and the right species of cyanobacteria that actually trigger real human illness. But when they do, it's quite scary. There's different toxins that's been described that can affect the liver, the kidneys, the reproductive system, even the blood system. And there's some that can actually cause seizures that have also been described. This is not something that any ordinary lab can test for, which is why the state is getting involved, is because they want to know if there are human effects. They're going to go out and test that body of water. Obviously, the first step is just to keep people out of it. So they're going to make it not conducive to human activity, but then they're going to go back out and test for whatever toxins there are. So they kind of need a better, more robust reporting system for these algal blooms. They actually are using some cool satellite technology that I can share next time we meet. But we actually have access to the software that they use, that they can see using satellite technology, where the lakes with the algal blooms are blowing up. And they actually have that on their state website as well. But this is just one very small, very narrow example of how climate change affects health effects. And I think it's just, there's more to come about stuff like this. So I find it very interesting at a lot of different levels, as you can imagine. But this is just, again, it's not theoretical. It's not just a global threat. This is what I would consider a very substantial public health emergency. And that's why I'm trying to educate myself and hopefully educate some of you about this, because I think that all of us are going to have to deal with the many imminent public health effects of climate change. So the call for action that we have is we're actually forming a work group to look at this. We want this to be a broad multidisciplinary work group. We'll work out exactly what the specific focus is, but we understand that right now we just don't even have enough information to know who's vulnerable. So doing a vulnerability assessment is going to be one of the first steps that we do to look at what are the public health implications of climate change. And this is something that, like I said, this is going to probably take many years to refine our methodologies, but it's not too early to start, because this is happening now, and I think it's only going to get worse and worse. So if you're interested in this, or if you have any skills in this area, please reach out to us, because we need you. And I'm really looking forward to creating a work group that can help us work through some of the very real threats of climate and environmental change that we're experiencing here in Fresno County, whether that's air pollution, drought, wildfire effects, water effects, or mosquito-borne diseases and other pandemics to come. So what I actually wanted to call this work group, again, my team wouldn't let me do this, but I was going to call it Operation Stranglehold. But instead, we're going to call it boring Central California Climate Change Clinical Collaboration, or C6. So thanks to my team, I couldn't have a cooler name for this, but hey, C6 is good enough. So please join us. Again, the call to action is research, surveillance, education, advocacy, preparedness, mitigation, and ultimately recovery for the inevitable tragedies that are to come. But the more that we prepare, I think the better position we will be, and the more we can serve our communities. And like I said, it's never too late to start. That's all I have. We have about 5 minutes left for any questions. So please go ahead and speak up. And just a reminder, we're doing our part to help with the blood shortage with a blood drive tomorrow at Fulton Mall. So for those of you that are working in the downtown area, you can use our facilities to come in and donate blood. Otherwise, please remember that that's always a perennial shortage that we need help with. Thank you so much. Any questions? Let me check the chat while I have a chance. Do we know what the 7-day case average positivity rate for 100,000 for COVID in Fresno County? Yeah, I think we shared that. It's right now 2.7% from the slide. Depending on what site I look at, I get a different number. Yeah, that is absolutely understandable. The way that we calculate our average positivity rate may be different, just depending on what people are using as their bookends, but also how they define positivity, whether that's test positivity or symptom positivity. So it just depends on what people are looking at. I don't think that they're too far off, though. They're usually similar to each other. And I think that the larger story is that it's going up, which is very concerning. So regardless of what the actual number is or which site you look at, the numbers seem to be going up statewide and countywide, and that's being reflected in our positivity rate. Any other questions? Wow, I think we put everyone to sleep, Sim. I think we do get questions about how to get variant testing done, and that's super important to know. Please try to work that out beforehand, before you have a breakthrough infection. But really, anyone who's hospitalized, anyone who's fully vaccinated and then gets COVID, those are the people. And then anyone who's involved in a cluster, meaning that their family member has been told they have Delta and now they catch COVID. Those are the folks that we want tested for variants. Reach out to us if you're having trouble getting variant testing done. Depending on which lab you use, sometimes they can do it themselves. Otherwise, we can actually get the specimen sent to the state or help you get your specimen sent to the state. Like I said, there's a 2 to 3 week delay. So even though we're saying we have 21 Delta cases here, that number could be 200 today and we just won't know for 2 to 3 weeks. So that's the real difficulty with variant testing right now. I think we have to look at this as a population level delayed analysis, not a real time, something that's going to help you at the bedside. What you need to know if you're working in clinical practice is be absolutely mindful of your masking, be very careful with your unvaccinated staff, and then just expect that you're going to see more COVID in the next few weeks.
Dr. Vohra, Rick Limbo, how are you?
Hey, Rick. Good. How are you?
How are you? I'm good, thank you. Let me do that. Out of the variants, and I may have missed this because I'm seeing patients, I ran in and out. Do we know how many of those may or may not have been healthcare providers out of the variants that were positive? Is there any way to, is it affecting a certain population? I mean, I know the number's small still.
Yeah, I actually don't know off the top of my head. Whether the ones that, because I see two sides of this,
Right.
The ones that are on the public health side that we know about, the 21 Delta cases, I don't think any of them were healthcare providers that I know of. But on the other hand, I'm also hearing about healthcare providers that are getting breakthrough infections.
Right.
I don't know for sure what their variants.
Right. And you would think that frontline workers or health and any of the frontline workers, not just healthcare, because they're going to run into the public and interact more, their exposure is going to be greater, right?
Yes.
Just like it was non-variant 12 months ago.
Right.
with those variants of the vaccinated, and I know this is early and we may not want to go there, is there a trend of the mRNA vaccinated population versus the non-mRNA vaccinated population yet? Too soon?
It seems to be too soon. The one slide that I showed actually.
I may have missed it. So if this is repeat, I apologize.
No, it was basically from the state. There's a study that looked at Johnson & Johnson, and it says that, it neutralizes 1.6 fold. The antibody neutralization is 1.6 fold lower whenever you have Delta variant, whereas Moderna, it's 2-fold reduction. So it's like they're both very similar, and they each had 8 subjects. So it's like, what are you going to do with a sample size of 8 in each arm?
Right, and that's why
hardly a study to compare. So I just haven't seen any credible studies that answer the question that you're asking, which is, which type of vaccine is more protective,
at this point,
or adenoviral?
Yeah.
Now, I don't know that we can really say.
The messaging still is whichever vaccine people ask, which vaccine is better and more protective, whichever one you can get. Okay.
Yeah.
Thank you.
Sure. And remember, even if you get COVID as a breakthrough infection, odds are you're going to beat it really quickly, because you're fully vaccinated and your immune system is going to fight that infection. So even if you get a very mild symptoms and you end up getting tested, odds are still that you're going to stay out of the hospital by leaps and bounds compared to the unvaccinated person. So,
do you foresee a rapid test in the future that will test for the variant, or it'll still be PCR? Indicate PCR and then indicate you want variant testing.
I don't think that's a short-term future goal. I think a long-term future goal, maybe.
Okay.
I haven't seen anyone even deploying a pilot.
Deploying anything. Okay. Thank you.
Sure. All right. Well, we are at the hour. If there's no other questions or comments, or if you just don't want to speak up and email us instead, that's totally fine as well. Certainly appreciate the conversation, and I wish you all a safe, happy, and cool rest of your week. Enjoy time with your families and take care of yourselves. Thank you so much.